5, so let's begin. So let me start off. I'm Jim Sherry with the CUNY Center for Immigrant, Refugee, and Global Health. I'm very pleased to be here today with co-director Dr. Kathleen Crivero and two other directors from our center, Diana Romero and Rishi Sood. And so it is it's our pleasure today to be able to welcome just a distinguished leader in this field, Bernadette Kumar. Dr. Kumar is actually joining us today from Kathmandu. And though that is not the topic of her COVID and what's going on there and in the Indian subcontinent, where she did her original training at St. John's Medical College, is not the topic of her presentation. We're hoping that we'll get a few words from her on that at the end and some guidance there. Bernadette has just been a leader in the area of immigrant health. After her medical degree, she went to Oslo, and there she did her doctorate in epidemiology and public health, and was actually the force of nature that began the Norwegian Center for Migration and Minority Health, which was, as we at CUNY were beginning the discussions about how we would do a center in this area, that is where we visited, and that was what we most were impressed by. It's like, that was our gold standard. If we could get to something like this, like she had managed to do there, then we will have succeeded. We're not there yet, but now with also Bernadette being a part of our advisory process here and active with us, we hope to get there. She went on from there. She's served, and where our paths have crossed, and WHO and UNICEF and the World Food Program at the World Bank, and of course at NORAD, her nation's bilateral program. I should mention that the Center for Migration and Minority Health is now a part of the Norwegian Institute of Public Health. So Bernadette continues a relationship there, but is now back where she likes to be, on the front edge of things. But nevertheless, she's still heads up in the European Union, the Public Health Associations, the Working Group on Migration and Ethnic Minority Health, and importantly, coming out of what many of you I'm sure have seen, read the Lancet series in this area. Now there is Lancet Migration, which we're looking to hear about, and Bernadette is co-director of that initiative, which is a large collaborative of efforts, academics and others trying to bring attention to the science issues here. So I know she has a lot to say, and so without further ado, it's my great pleasure to introduce Dr. Bernadette Kumar.
Thank you so much, Jim. Thank you so much to CUNY Center, to all the colleagues there, and for this invitation. And when Kathleen approached me initially about doing this talk, and I discussed it with Kathleen and Elizabeth, it was a yes straight away, because I think it's so important for us to have this communication both across the Atlantic, but also, the global perspective on working on such an important issue. So I think you're well on your way, Jim, at CUNY, and I really look forward to seeing you all also achieve many of the same successes that we've had, and also when things get tough, that we are there to support each other. So I'm just going to start my presentation. And as you will all discover, there are two things you need to know. The first thing is that I speak very quickly. You will have the slides later, and I have a lot to share. So if I do get a bit sort of enthusiastic and carried away, you'll know it's because this is a topic that is really close to both my work and my heart. So what I'm going to talk to you about today is migration, our reality and our future, and why migration is really a defining issue for health. And at the outset, I'd also like to thank and acknowledge my colleagues, Sally Hargreaves, Esperanza Diaz, Dr. Santino, Miriam Urkut, and Raj Gopal. So what am I going to talk to you about in the next 30 minutes or so? I'm going to start with an introduction. I'm going to do the who, what, why, some key concepts and definitions because even though we all think we understand what migration is and what migrants are, it may not be the same understanding. Why migration health is a defining issue, and we cannot ignore COVID-19 and what's happening. And COVID-19 and migrants is also a very important area, and a little bit at the end about the way forward. So I hope all of you have fastened your seatbelts, because here I go. So we have 1 billion people on the move, and you might say, my goodness, 1 billion people on the move. Migration is part of our past, it is our present, and it will be our future. When we talk about 1 billion, you say we've never heard these figures before, because a lot of migration actually happens within borders. But the people we talk about a lot when we talk about migrants are the international migrants, and they're the 258 million or so who cross borders, and they're the international migrants. And the migration experience is very different, and it sets migrants apart from other disadvantaged groups that are facing inequalities. And from a public health perspective, and I will talk about that a little bit more in detail, migrants face inequalities in health, inequity in access to healthcare and services, and also they have experienced racism, microaggressions, and structural inequities. And that's why our Lancet Commission was really developed in the light of the opportunity to realize the SDG commitments, to leave no one behind. And we know that worldwide mobility is our future, regardless of laws and walls. And therefore, it was very important for this commission to bring forward some of the key recommendations that I will also talk about a bit later. So the relevance of migration to public health. With 1 billion people on the move worldwide, migrant health has become an essential part of public health. It's a global reality, and we see that there is the long-term globalization and unequal development patterns, and then there's forced migration. And forced migration is a result of conflict and war, but it can be natural, man-made, financial crisis, and climate change. So migration is not something that we can very quickly reverse. And even with the COVID-19 caveat that we're going to see, it's not something in the future that can be stopped. The health of migrants, and maybe it's not something we want to stop either. The health of migrants and health matters associated with migration are crucial public health challenges faced by governments and societies. And some countries are well prepared, but often there's a need to have an urgent coordinated response to address short-term and long-term implications of migrant health. Health systems in receiving countries often need to ensure health services access for migrating populations in order to protect and promote their health. So we cannot separate the health of migrants from the health of the rest of the population. And this we've seen very clearly in the last year with COVID-19. Who are we talking about? When we talk about migrants, it seems like they're one big group, and they're actually an extremely heterogeneous group. You have economic migrants, you have regular migrants, you have irregular migrants, you have trafficked persons, asylum seekers, refugees, and these are all, there are different definitions that exist in different countries. Some of these definitions are legal definitions, some of them are definitions we see that the Bureau of Statistics use, and then some of the definitions are simply labels that we give people. And those labels change because there's a language of power. For example, if migrants are successful, they're often not called migrants, they're called expats. But the migrants who we don't want, maybe we call them with different names. So that's also an issue. But one thing that's important is the reason migrants have a lot in common, even though they're different groups, is that they're different from the host population. And we'll find out what are the differences. And so we need to bother with migrant health because the migrants are a very heterogeneous group that we need to understand. Migration patterns and pathways are varied and complex, so we need to look at a life cycle approach and epigenetics. Neither migration nor health are static. So there's always transition, there's always a change, and we need to follow that if we're going to understand what are the impacts on health. There is a need to dispel migrant myths, identify some of these, and I also discuss what can be done. This requires also policy coordination across sectors. And I think also for us in public health, it's very important that we focus on preventing illness and saving lives. And there are two things that I would say that is very important why we should bother with migrant health is one is that we need to change the narrative. We need a paradigm change. So an investment in migrant health is an investment in the future. Migrants should not be seen as a burden, but rather a resource. And we also know that universal health coverage and the SDGs will not be realized unless migrants and refugees are included. So now I'm going to give you, in case that those arguments didn't work, I'll give you 4 concrete reasons, or the arguments I call, why we should bother with migrant health. The first is the rights argument and the right to health. And the right to health must be enjoyed without discrimination on the basis of race, age, ethnicity, or any other status. And though this seems so implicit and so important, we know that there are many states that do not that have not ratified to the rights and the rights argument, and therefore this may not be enough. The other argument, which is the big argument, is the economic argument. And we know that health and wealth are very much related, and poverty and ill health are very much related. There's been discussions about how migrants are a burden on society, and I will show you the evidence from the Lancet Commission a bit later, where migrants have been seen not to be a burden on high-income countries. And we also know that the macroeconomic analysis on effect of asylum seekers in Europe included positive effects on the host country economies. And often we see that migrants in high-income countries actually work with providing medical care, teaching children, caring for older people, and supporting understaffed services. So the argument that migrants are a burden on the economy, it doesn't really hold true. Then we have the crisis argument. And the crisis argument is a very important argument because with crisis, whether it's man-made or disaster, we saw in 2015 the exodus from Syria, and you can see these boats, and everybody has seen these pictures, or you can see these are the migrant workers who had to walk back to Bihar in India last year after the lockdown. So we know that regardless of the situation, when people have to move because of the situation, they will keep trying until they succeed or die. So therefore, it's an important thing that one has to take care and take into account migrants' health. And then we have the anti-discrimination arguments. We know that there has been growing xenophobia, intolerance, there are hate campaigns, mudslinging against migrants, scaremongering, deliberate misinformation, outright lies. And this is something, again, that does affect the health of migrants and makes it important for us in public health to actually find out what are the myths and what are not the myths. And my final argument as to why we have to bother with migrant health is the strongest argument, I would say, of all arguments. And this picture, it's a very powerful picture, and all of us remember this. And we remember this little boy called Alian Kurdi. And what Manuel Valls said was, he has a name. His name is Alian Kurdi. So migrants are not just a faceless, nameless group of people. They're also human beings. And the humane argument is a very important argument for all of us to bother about migrant health. And if you're still not convinced, we can talk about it in the Q&A section. Okay, moving from that to looking at why in public health, we all are familiar with the social determinants of health, but migration is also one of the determinants of health and has slowly over the years become what I would call an independent determinant of health. And going from the old laws of migration about rural to urban and young men, et cetera, we know that there are many facets of it. It's political, it's social, it's environmental, it's cultural. We also must take into account that there's a migration cycle. And migration is not necessarily something which is linear in nature. So you have the country of origin, you have pre-departure, and then you have the journey, so to say. In the old days, this journey could take a very long time. Nowadays, we also know that this journey could take a very long time because they could be holding in different countries. So it could be short-term transit, it could be long-term. And we know some groups actually have been for the longest time, might spend an entire lifetime doing that. And then they reach the country of destination, which could be either temporary or permanent. And then some migrants do come back to the country of origin, but not many of them. And the health, therefore, of migrants has to be considered within this migration cycle process. The other thing that happens at the same time is, I always say, migration, the health of a migrant or the life of a migrant doesn't start when they land at a particular airport or port. It actually, as we know, starts, like with all of us, in the womb. And therefore, you have the history of the parents, you have a whole process during the life cycle where there are different exposures. And depending on when migration takes place, early or later in life, there will be factors that will influence the health of the individual. And it could be environmental factors, genetic factors, contextual exposures, etc. And then again, when the migrant is in the new country, in the new home country, or the country of destination, we also see that the factors there will influence. And it also goes on to the next generation. So you also have epigenetics. So therefore, you have to consider both the exposures that happen during the migration cycle, but also during the life cycle or the life course of the individual migrant. And what really changes? I think that some of you might recognize the picture that I have here. And I should have, if we were sitting in a setting where we could see each other, I would throw the question across to all of you and say, do you recognize what this picture is? And I think it's very relevant that it's the CUNY talk that I'm showing you this picture. And I show it often when I talk because it is Ellis Island. And it's very interesting how Europeans who landed there then became Americans. And so what changes is everything: the physical environment, lifestyle, the psychosocial, the networks, the changes in profession status, and of course, health also changes because risk factors change over time. And what usually happens, and I'm not really sure we can see that in this particular picture, but there's a euphoria, and you see that with a lot of migrants who actually, especially when you see photographs coming in from boat migrants, or when they land, people are really, thrilled to have made it. And then after that, it's often followed by a period of disillusionment, which is common, and then finally a period of adaptation. So there's a process. So we can summarize it that the opportunities that migration provides to migrants is new economic activities, poverty reduction, increases in wages, but it also has challenges with disrupted social networks, labor exploitation, and access to critical services. And what we really see migration is a bridge to global health, because it actually does bridge the health of several countries. So you have countries of origin and you have destination countries. And then migrants, while migrating, there will be a change in the disease burden, there will be a change in the health risk, and that will definitely affect the disease burden, health risk, health beliefs, health infrastructure for the destination countries, but also countries of origin, because you have a group of people who migrate and then they come back. So I think migration is something that touches all in this particular case when people migrate. Migration and health research often falls between the cracks. And this has been because the migration research traditionally has been done a lot by people in the social sciences, the demographers, etc. And health researchers usually have focused on disease and disease burden. So migration health research has often fallen between the cracks, but I'm very pleased to say that over the last 20 years, this has been changing constantly. And what we have seen is that the interest in migrant health started off with looking at the exotic disease phase and what was unusual in these migrant or ethnic minority groups. The study of biological differences followed after that. Then the population patterns, including mental health, comparing the host populations with migrant populations, and now looking at going beyond that, looking at adapting healthcare policy, research, and services to meet the needs of ethnic minority groups, and to look at diverse communities and look at how can we really prime the healthcare system to meet the challenges of multicultural healthcare. When we're looking at health research, and some of the health research that has been done has actually generated some hypotheses, and some of these hypotheses have been confirmed, and some of them still need to be confirmed. The most common hypothesis actually originated in the US with the healthy worker effect. And now we call it the healthy migrant effect, or the healthy migration effect, because obviously to work, you had to be healthy. And it's the same with migration, because it's a long journey. So usually it's a healthy group of people with resources who migrate and reestablish themselves and to be more resourceful, also health-wise. But of course, because of migration taking place due to man-made disasters, and sometimes it might be perilous journeys where they might be exposed to a new set of health risks, and mortality and morbidity are increased by movement. But usually the health of migrants is not bad when they start the journey or when they arrive in the destination country. However, the healthy migrant often becomes what we call the exhausted migrant. And this is the theory of the allostatic load, which goes to the core of migrants' needs to adjusting to the environment. There's a lot of stresses, and there are a lot of changes in the risk factor. And all of the sum total of all of this leads to the exhausted migrant. And then there are a couple of other theories that I will mention, but it's difficult for me at this stage to go into it. But I would strongly suggest that a lot of the students at least think about the salmon effect, acculturation theory, social causation. And the last one, do we find these differences in health of migrants because it's a data artifact? And you know that that's not really the case. We know that these differences are really real differences. So just to summarize, if you look at the general model for the effects of migrant status on health, you have the direct effects through specific mediating process, that is genetics, that lead to ill health. You have sometimes the effect of migrant status working through the socioeconomic factors, poverty, or you have the exclusionary processes, which is discrimination or exclusion when it comes to health service availability, entitlements, etc., etc. So all these things act in concert together and often result in ill health for migrants. Moving on, so what do we know? And these are some of the findings from the Lancet Commission. And I've already mentioned the issue of migration being a determinant of health, and also that the migrants are in general, on average, healthier, educated, and employed. So when we think of migrants and we think of migrant health, we mustn't always think in the negative. But however, we have subgroups that are exposed to harm, trafficking, irregular migrants, low-wage migrant workers that are exploited, asylum seekers, etc. So what we also found, which is a very important finding, that the percentage of labor migrants is actually the largest group if you look at here. And often when we talk about migrants, we think about asylum seekers and refugees. And of course, they are rather disadvantaged, but some labor migrants are also disadvantaged, but in particular, the low-wage labor migrants, as we know. So what were the myths about migration and health that were not supported by the available evidence that we brought forward in the Lancet Commission? And some of them I'm just going to go through very quickly. So migrants are not damaging economies. And in advanced economies, we saw that each 1% increase in migrants in the population increases the GDP to 2%. And also remember that migrants were sending remittances to their families in the country of origin. So migrants are not damaging economies either in the home country or in the country of destination. And there's overwhelming consensus of evidence on that. The other thing we saw, that migrants are not a burden on the healthcare services. And I will come back to a couple of slides here that will talk about that. The other thing, there was the populist rhetoric that migrants have many more children than the host population. But it was interesting that the data we saw that very soon after migration, migrants have lower birth rates than non-migrants, with the exception of, for example, Turkish women. And the birth rates of migrants almost were at the same level of the population replacement as the host population. So again, this whole rhetoric that migrants are going to overtake the host population because they're going to have so many children is not supported by the evidence that we have when it comes to birth rates and fertility. And then I'm going to show you a couple of slides that actually, I don't think I have the time to go into detail, but they're basically looking at, these are registered, this is from Norway, and in Norway we have very good register data like the rest of Scandinavia, and like in Sweden and Denmark. And you can see there that there was always this thing that migrants often overuse the primary healthcare services. But when we look here, we see that the migrants, particularly migrants from other income countries, which means low and middle income countries, not migrants from high income countries, which would in Norway would be neighboring Sweden. They're the ones who used the primary healthcare services more than the migrants from low and middle income countries. So we've seen that we do have a lot of knowledge. We've seen that there's been a great increase in publications over the past 2 decades. However, what we see is that both in terms of where the research is conducted and on what topics the research is conducted is, of course, not evenly spread out. So we know that the knowledge currently produced is not sufficiently used to facilitate policymakers in closing the policy practice gap. We see that very little attention is paid to the determinants affecting incidence of disease. We see that there's inadequate knowledge on effective preventive interventions. We see that we have very few longitudinal studies that incorporate various comparison, and especially the focus on the causes of the causes. And we don't have studies that evaluate policies addressing causes of causes. So while I'm not going to sit here and say that we don't have data, we do have data, but it's far from enough. And the data that we have, and I'm going to show you an example a bit later, is not used in decision making. So research is definitely important, but what is also very critical and key in research is that user involvement. And the thing about nothing about us without us, migrants have often been excluded from research, and there's a fatigue of being researched. So in the collaborative research, there's a ladder of inclusion where migrant communities and migrants should be both, not only part and parcel, but very much from the start of the design of research, a part of the research that is conducted, for the research both to be meaningful, and then of course also in terms of implementing some of the strategies and policies that do come out of that research. Okay, so now I'm moving on to a very important overarching issues, COVID-19 and migrants. And currently today, we know that you cannot think, breathe without thinking of COVID-19. It's all around us, and therefore it is definitely an issue of concern, and so is migrant health. So what has happened with COVID-19? There's an exacerbation of pre-existing structural factors in migration contexts. Migrants often have an interaction of multiple factors, which make them at a higher risk for COVID-19 infections, high morbidity, and mortality. And what COVID-19 has done is it has exposed some of these structural gaps in the access to and quality of health services, barriers such as language and accessing healthcare. The existing inequalities within our societies have simply been unmasked. And in particular, we know that poor and crowded living conditions, pre-existing poor health and comorbidities, and the economic precarity. So it's really as if for migrants, this was the last thing one needed. And unfortunately, COVID has done exactly that. And then we have the political factors. In addition, the existing social and political responses to migration and migrants with xenophobia and racism. So this was just, the disadvantages of already existing health system failures, as well as immigration policies of deterrence and externalization of borders. So what do we know? This is colleagues of, across in Europe. We did a systematic review, and as you can see, most of the data is from 82 high-income countries, and you can see these are the studies that were included. There are 33 sources, and there are quite a few studies from North America. But as you can see, that the Nordic countries have a lot of data because we have these wonderful registers. So it was quite easy actually to collect the data. So sometimes even though the data is there, it's like data everywhere and not a single figure to get because often it's not prioritized and often data is not presented in that particular fashion. But you can see from the rest of the globe, and particularly low and middle income countries, and when you look at Latin America, when you look at India, when you look at a lot of other countries, there's very little data, and if the data is there, it's very unreliable. So what did we see? And it's not only just COVID-19 data, but it's COVID-19 and migrants, which makes it even more challenging. So the primary outcomes are divided into cases, hospitalizations, and deaths, which interest all of us. And what we've seen is a disproportionate number of cases among migrants. Lower, for example, in Norway, the number of among the migrants, there were about 35%, whereas the population proportion of migrants in Norway is only 18%. And that's what we mean by disproportionate number of cases among migrants. And similar figures were seen, for example, from Sweden. Lower rates of testing, but higher percentage positivity. Outbreaks in high-risk settings like camps, detention centers, dormitories. In the hospital, it's harder to get the data. So we have limited evidence from there. But we also see there's an increased risk of being hospitalized and admitted to the ICU. And similarly, we see for deaths that it's very, very much higher in terms of mortality. The reported cases of coronavirus in communities and dorms, and this is some data coming from Singapore, where we've seen that because migrants and often labor migrants live in dormitories and they live in very crowded areas, the comments that were coming is day and night, we are just in one room. It's actually torturing our mind. It's like jail. And there's a lot of suffering that is taking place. And as Richard Horton has said also, the COVID-19 pandemic is not just a pandemic, it is also syndemic, because we see that there's comorbidities as well as there's other issues beyond the health sector that need to be addressed. If we look at the US data by race and ethnicity, this is from the CDC, it's very clear when we look at the same cases, hospitalization and death. You can see that Black or African American non-Hispanic persons was 2.6 times higher in terms of cases, hospitalization 4.7 times higher, and death 2.1 times higher. And therefore, it is definitely that race and ethnicity are risk markers for underlying conditions that impact health. And I think it's very important to understand that here one shouldn't go immediately to the other extent, which has happened in some places, to blame the victim. Very often, these are the people, these are the communities that are frontline. They are the essential workers. They are the people doing the dirty, dangerous, difficult jobs. And so it is not surprising that we see these figures. And similarly, this is also the case in the UK, where you see that Central and Western Africa, the proportion of those, the all-cause mortality was really higher than a lot of the other groups that we see over here. So we also know that COVID-19 in refugee camps and facilities is both a very big challenge because of the living conditions. We also know that COVID-19 is very contagious, so outbreaks are absolutely devastating. We also know that the healthcare services and the systems in a lot of the refugee camps, as well as in facilities, are far from desirable. So therefore, it's really waiting to explode. And in a lot of places, there have been outbreaks, but in a lot of places, I have to say that because of countries planning and understanding that there should be prevention and there should be containment, action was taken, which was required in time. So what are the reasons that ethnic minorities are at a greater risk of COVID-19 deaths? So you can divide them at the fundamental level, the societal level, and the individual level. When we look at ethnicity, we know there's a differential exposure. When we look at infection, there's a differential vulnerability. And when we look at disease, there's differential consequences. So even though this looks very complex, but all of these factors actually link in very much together. And therefore, it is not enough to only address the top of the iceberg, so to say, but also to some of the underlying causes. I don't have the time to go into the differential exposure and differential risk and the differential impact, but I think that the slides will be available, so you will see, and you will be able to you have the slides afterwards for those of you who want to go into. But differential exposure is very much going back to where the migrants are, what kind of work they're doing, their living conditions, and that has a great impact on, again, their differential risk and the impact of COVID-19. Okay, I'm also going to just skip over this slide because this is also, again, why they're vulnerable and why they have the increased likelihood of contracting COVID-19. Lancet Migration, we've produced situational briefs from both all over the world, as well as regional briefs looking at migration and migrants and COVID-19. And basically what we say is that COVID-19 is one of the greatest public health challenges that our generation has ever faced. We must use it as an opportunity to strengthen health systems and build health systems that are truly inclusive of all marginalized populations. We simply cannot afford to leave people behind. And I think this includes various things that need to be addressed for migrants at various levels. Okay, I can see that I'm running out of time. So I'm just going to say that when it comes to how does all of this translate into action on the ground, and for that, there have been several initiatives, both at the global, regional, and national level. And all of these initiatives have really come for a call to pay attention to migration, and of course to migrant health as well. So in the 20th century, what was the main concern was access and quality of health services. But for the 21st century, it is not enough to stop at access and quality of services, but to go further, to look at issues related to governance, to look at issues related to intersectoral collaboration, look at data and research, and to really work across the sectors in making headway with migrant health. So we really need to engage the policymakers and stakeholders in reducing migrant health inequalities. And we know that evidence matters, governance matters, and we can't really allow people to say, it's not our concern, we don't know what to do, we don't know how to do it, we don't want to do it, we really don't want to do it, we can't afford to do it. So we have to change this rhetoric, and therefore we have to change that narrative. So as a researcher, I will always say that we need the evidence, but the evidence must be used. And we can see, for example, I haven't had the time to talk about vaccination, but migrants have not, given their vulnerabilities and given their overrepresentation in the statistics, it's really interesting to see that when it comes to vaccines, it's not a group that has been prioritized, or one has not seen the need to do that so far. So I think we need to use the evidence to bring about policy change. The moment for migration is now, and we see a lot of initiatives like the SDGs, the Global Compact on Refugee and Migration, the WHO strategy, the Global Society, Lancet Migration, and also the CUNY Center. I hope all of us together can really work to make this, to unite, it should unite us rather than divide us, as Justin Clark and Richard Horton say. Finally, I can't not quote Martin Luther King, who says, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. And I also have to say what Gandhi said, that you have to be the change that you want to see in this world. Thank you very much.
Thank you, Bernadette. This is where if we had a soundtrack, we would be able to appreciate the applause, but we'll save those few moments and go right to our discussion. Just to give people an opportunity as they're collecting their thoughts and sharing that, I hope, with us in the chat box. Dr. Crivero will be moderating the conversation in just a couple of minutes. I'll be chipping in. But first, there are three members of our center, including our dean, who who's been the longstanding champion of CUNY's work in this area, and is also taken his dean's hat off today, and he's now our participant in our center. He'll be one of those. But I want to start with the professor of community health and social sciences, Professor Diana Romero. She's also serves as the research director in the center. Diana, I'm looking for you in the, there you are.
I'm here. Yeah, thanks. Thank you so much, Dr. Kumar, for a really terrific presentation. I think it laid a lovely foundation, and then certainly with a lot of specifics, and particularly on the research and the data side. I was struck, with your review of the four, arguments that we can make, public health arguments that we can make for caring about the health of migrants. And at the same time, as you went through them, I was sadly reminded that at least in the US context, I feel like we have not succeeded anywhere near where we need to in trying to make those the human right, or the right to healthcare certainly is very contentious in this country. We've tried to make the economic claim, like for example, government health insurance through our Medicaid program for low income and other populations. The argument has been made that emergency Medicaid that sometimes can be provided for individuals who are not, don't have documentation in this country. Certainly, the expenditures in emergency settings, right, and in late stage disease settings is much higher than if this population of our country were just provided, with that, so that preventive care and primary care can be sought. And then, I think those human images hit people at a moment, and then they just sort of go back to what sadly in this country is, I think, a political demarcation on this issue of migrants and health. So we just haven't been successful. And so I wondered, for me, it seems like it's just all about the political divide and how to work through that. But I wonder if it's also a communications problem. If we have data, if we can make the case about sort of the economic imperative, the human rights imperative, have you seen contexts similar to maybe the US context where that has been more successful than for us, other accepting countries?
I think that you raise a very important point, and I think even for countries that have been successful, the success has really taken a very, very long time. And one of the issues, I have to say this myself as a researcher, and a lot of colleagues around, will say the same. We're very interested in getting our articles published, and then we think the job is finished, and that's where it begins. And then we really don't engage a lot with policymakers because we think they should just read it, but we have to chase them. And I think that we don't have many platforms where we can actually, without the glare of the media and social media, because often if those kind of discussions only happen in the glare of the media and social media, then politicians and policymakers feel very much cornered. And then, of course, they stick to their guns and they're not changing any of this. So I think what we need is really to have a steady, quiet dialogue all the time that is not in the glare of the, as I said, media and social media, and not with the idea of saying you haven't done this and you haven't done that, but actually coming up with solutions and saying, why don't you do this? And for example, I can give you a very simple example from COVID, in Bergen, the municipality of Bergen. And in Norway, just like with every other country, the undocumented or irregular migrants don't have any access to healthcare services. And as soon as the pandemic started, this was very quietly taken up by colleagues in Bergen who said, well, we don't know where they are, and we don't know if they're contagious and everything. Can we not just let them use the services? And that's what the municipality of Bergen said, yes, because it's in our interest that we don't have them where we don't know if there's any spread of the virus, or we can't contact trace them, and we can't make sure that they're isolated and get the right treatment. So I think it's really it's a lot of hard work. So I would say we mustn't be disheartened, but we've got to sort of support each other, and we've really got to engage with the policymakers at a level. And I would say where most successes, and this is also colleagues in Europe have seen, not at national level. It often works really well in municipalities, in boroughs, you know, where you catch hold of the local government officials and talk to them and say why they should be doing this, because it is in the interest of that particular area, and that works.
Thank you. If I might just comment on one little thing, I love the point that you made about not in the glare of the media, because I think we have a lot of initiatives, you know, at all different levels to try to train researchers in advocacy so that, you know, they can do evidence-based advocacy. But somehow I think a lot of the programs I'm familiar with automatically go to doing so sort of with the big, you know, big attempts at a big splash. So attracting media, you know, doing it so that it ends up in national newspapers. And I really think it's incredible the point you made that oftentimes policymakers may be willing to do something if it's a little bit that's not in line with their political sort of platform, if it's not very, you know, noticeable. So I appreciate that.
So if I may, and I'm noting that Ayman has his hand up and that works. And again, pardon my, this is why my more able colleague Kathleen will be moderating and not me, because I'm only noting that. But that is, I think, a reminder to us all. If you have a question, please, and you can find the way to put your hand up, that's great, do so. Otherwise, if you put a note in the chat box, Kathleen or I will find it. I'm going to come to Ayman in just a second. I want to first go to our public health practice director in the center, Rishi Sood, who also, interestingly, serves as his day job, if you will, is that the other part of his time when he's not with us in the center, is he serves as the Director of Healthcare Access and Policy at the New York City Department of Health, and has served as the acting Assistant Commissioner in the Bureau of Equitable Health Systems. Rishi?
Thank you so much, and thank you, Dr. Kumar, for a really engaging and informative talk on such a critical issue, and for highlighting race and ethnicity data related to the pandemic, which I think really helps make the case for getting more and more improved and increased quality and access for migrants. I also want to, before asking my question, just sort of thank you and second your comment about the importance of political leaders at the local level. And as a local public health practitioner myself, I have a firsthand experience in convincing local political leaders to make changes that may not happen at the state or the federal level here in New York City. And I think that it's really important to start at the ground up. I spent a lot of my time talking to other public health officials in different jurisdictions around the country who are trying to sort of do what's happening in other cities or jurisdictions. I wanted to ask you about the impact of migration and the literature and research on impact of migration on services more broadly than healthcare services. You talked about this in your talk, and I very much appreciate the reference to the fact that we know that migrants don't tend to use more healthcare services than native-born populations. But I did want to ask, and I think that this really can help in messaging when making the case to improve care and improve access, is does it differ by jurisdiction? And are you aware of any research that does show that in certain countries or cities or regions, migrants do tend to use more services, at least temporarily, even if it's not healthcare services?
Yes, I think that's a very relevant question, and I think that they do use some services more than other services. It also depends on where they are in the process of migration. So newly arrived migrants, for example, will use services more often. And one of the things that I didn't show, but there is data that shows that people who have migrated recently, they often go to the emergency care services because they don't really know, they have not been assigned a GP, they don't know how the preventive services work, etc., etc. So that is one of the challenges. And similarly with social services, that initially when they're in a country, they may not be using the social services, but later on they do understand how the system works. And this is whether it comes to employment or rehabilitation or any of those services, they do use that after 5 years. So what we've seen in all the research is that the services are, and they use only the very basic or absolutely essential services, mainly because they don't know how to navigate the system. And so once they understand how they can navigate the system, then depending on how long they've lived in a country, 20, 30 years, you'll see them using the services the same way as the host population. So that changes with time. Now, interestingly, you might think that some services would be important for the migrants to use, like translation services, but they don't, because again, they don't know about the services, or if the services cost a lot, then they may not use those services. So it varies a lot in terms of where they are, and in terms of both in terms of where they are in coming to the country, understanding how things work. And it's very different from their home countries. But once they understand how it works, then they do use the services. I hope that answers the question.
Yes, thank you so much.
Okay, yeah, Ayman.
Bernadette, please allow me to call you that, since I feel like we are brethren of the same spirit. I'm extremely honored that you chose to join us today, and the School of Public Health at CUNY welcomes you as a new member and definitely a soulmate and a friend. What a riveting presentation. We are very grateful for you to have presented so succinctly and clearly the topic at hand, but also to continue to alert us to the importance of the impact of immigrant status on the response to COVID. I just wanted to remind everybody that of the 1 million immigrants that come to the United States every year, a population of 320 million people, quarter of all the immigrants that come to the United States come to New York City with a population of 8 million. And it is not surprising that when we started this venture of our Center for Immigrant and Global Health, we decided in New York that Immigrant Health would be such an important cornerstone of this activity. I'm also very aware of the Institute of Public Health in Oslo, and in my previous life was very involved with their perinatal group, and now I am going to be a fervent fan of this group of researchers in immigrant health. Having said that, I think one of the areas that are of interest are subcategories within immigrants and migrants. And one of the intriguing statistics that New York unfortunately was not able to uncover fully in its connotation was subcategories of immigrants, because not all immigrants have been created equal. Number one, and you mentioned that in passing during your comments, and it is so very true and so very pertinent. The background culture, but also the socio-demographic and socio-economic conditions of various immigrant groups we know in New York City are unique to themselves. One of the most alarming statistics that we saw the Department of Health issue during the pandemic in New York, which hit early and hit hard, was that the highest mortality rate was amongst a category of minorities that defined themselves as other. They were neither white, nor were they Black, nor were they Hispanic, nor did they choose to define themselves as Asian. And at that time, anecdotally, it was reported that the onslaught of the pandemic on a small subpopulation of Bangladeshi immigrants in Queens had been so severe that they were barely able to bury their dead in New York City. And so the truth of what you shared with us today is striking, but the subcategories under that umbrella of immigrant status, as you pointed out, need I say transiently because your talk is so comprehensive, is of pertinence in terms of cultural disparity and linguistic disparity in immigrant status. So the predicament of the 50 million internal migrants in China is one thing, and that of Bangladeshi immigrants in New York or Russian immigrants in New York may be different. And I just wanted to ask you about the insights that you have about these subcategories, internal versus external, and the cultural dissonance between subgroups when they find themselves either culturally isolated or perhaps even numerically isolated, so smaller subgroups that don't have an underlying platform of a community that could receive them and facilitate this negotiation between the community and the healthcare delivery system. And I heartily thank you, and I welcome you to our community, and I do wish that you accept my personal invitation to become part of the advisory group for our Center in Immigrant and Global Health. And Kathleen and Cher and Jim, I cannot thank you enough for inviting this wonderful speaker today. Thank you so much.
Thank you so much, and I hope I can also call you Ayman, for this, for your really warm words, and I'm delighted to be part of the group at CUNY. And Jim, I've known for, we won't even count how many years, and I really got to know Kathleen and the rest of the team, and I really look forward to getting to know you. And I'm really personally very, very, I would say, excited that New York City, which is the host of so many migrants, is really able to take this up in the right way through your center. So I'm really excited about that, and also looking forward to collaborations with us on the other side of the Atlantic. Regarding what you've said, I think that there are many categories, and this is why I've said, on the one hand, it's okay for the BBC or the CNN to talk about migrants as if they were one group, but it is not okay for us as researchers, public health specialists, and epidemiologists to talk about them as one group. They're not. They're very, and heterogeneity, we've seen time and time again, is so important. And there are very big differences, both between internal migrants and migrants, as you said, the internally displaced, so to speak. And the migrant experience, and when, again, if this had been a lecture which was face-to-face, I often say that, go around the room, everybody has had some experience of moving. It's not the fact that it's so unique that it's only a few people. However, everybody's experience is different. So even though the experience is common, the way it's experienced is different, and all these different subgroups experience differently. And you see the differences also between migrants and the offspring of migrants, because you cannot call the offspring of migrants anymore. But yes, they have a history that is a bit different from the others. So I think that those differences are very subtle differences. And often those are differences that we are not able to successfully either capture or look at, and therefore issues like intersectionality become very important, because it's not only the fact that it's a Bangladeshi, but maybe Bangladeshi woman, maybe a Bangladeshi woman who's young, maybe. So there are many factors that actually, also intersect. That's important. So, and the difference is going to be in the cultural distance. So very often, the cultural distance between groups are there. For example, I can give you this example, in Scandinavia, where one might say, okay, but Swedes and Norwegians and Danes are all the same. Actually, that's not true. If you ask them, they'll say, no, we are different. But of course, it's very different from being Indian, or very different from being African, or being Bangladeshi. So it's the cultural distance between different groups that also we have to take into account. And what are those differences? And can those differences be defined? And often those are challenges that, for example, health personnel face. So when you have a patient come in, or when you're trying to public health message, or when you're trying to develop some kind of intervention, those are the issues that you need to therefore talk to that particular group and say, what is it that works? So I've always said to people, say, okay, what should we do with this group of Pakistanis or Indians? I'm like, ask them. Don't think that we have all the answers, because each of those people will be different. So I think that, unfortunately, this is a long answer to say that we don't have any quick fixes. And I mean, very often we're looking for quick fixes and we end up with Band-Aid. And as we know that the Band-Aid is very temporary. So we might have a temporary solution and say, okay, now we found how to reach the migrant groups. So now we found a way to reduce the disparity. But if it's not done in a very proper systematic fashion, then you will find that it's not going to stick very long. So I will say that the subcategories are extremely important. You also have to look and see the history of that particular group, the history of migration. And that's why I think also the multidisciplinary teams. And in health, we also need to work with the social scientists. We need to work with the demographers. And, you know, sometimes even though we may not always agree with the anthropologists because they have a very different way of looking at it, we have to consult with them and say, okay, how can we all together find a way of finding at the end of the day the solution, a workable solution.
Thank you very much, Bernadette. We have a question from Alan Krasnick from the Danish Research Center for Migration, Ethnicity and Health. And I want to take this opportunity to thank Dr. Krasnick for the support and advice he's given the center since we started. He was a very early call we made, and he was so generous with his advice and expertise. So it's great to be able to thank him for that. But Dr. Krasnick thanks you for your overview and asks, in what ways can we best push for inclusion of migration as a universal variable and determinant in public health, just as age and gender and social status are today? Like, do you see a way forward for that?
Yes, I think that what we have to do is we have to make the case for why migration is a determinant as much as the other determinants we talk about. And we have now shown that earlier on it used to be thought that socioeconomic differences were the reasons that we saw differences between migrant and the host population. But now with all the data that has been produced, we've seen that that's not really the case. And the same thing if we really look and try to adjust for a lot of these variables and these factors, we find that, that there is a difference. So now there's enough evidence for us. Earlier on, I think we didn't have enough evidence that could help to make our case. Now, from the evidence, we really have to begin to work very systematically, I would say, at 3 levels. First of all, we'll have to work with the statistic authorities, which is a very difficult thing because they have their own reasons for the census data and other data, et cetera, and then you have a lot of regulations where there are a lot of laws governing what you can have at that national level data. So, but unfortunately, we have to work with them and we have to insist and show them why the data needs to be disaggregated. And one of the case in point was exactly this COVID-19 data, which was then divided, both in Scandinavia and the UK and the US, as we saw that was important. The important group, however, that we can work with is our colleagues. And I would say these are the colleagues, researchers, schools of public health, epidemiologists, and really work with them and saying that every time, just as it's become almost, I would say, automatic that we have to disaggregate data by age and gender. We do that now. I mean, if people produce data that is not disaggregated by age and gender, people say, why haven't you done that? And I think that's where we need to work with in terms of our colleagues and saying, okay, when we have populations that we know there's a huge percentage, both like New York City, you may not have it in all places. You cannot not disaggregate the data by migrant status. So I think that's what we need to work with. And then, of course, we also have to work with some of the users of the data, because it's not only the producers of the data, but also the users of the data. And for the users of the data, again, if we have that relation with local governments and those and our health professionals, if they say, we need this data for our planning, we need this data for intervention, then people will start producing that. So I hope that it's not an easy task, Alan, and we're working on it, and it's an uphill task to get people to change the way they produce their data and change the way they do their research. And I think we just have to start with ourselves before we can get anybody else to do that.
Thank you, Bernadette. There's also a question from Katia Antia asking about how the family left behind by migrant workers, the children and the elderly left behind in the origin countries. They're not migrants, but they have very specific needs and concerns. And how can they become more visible to policymakers?
I think that in particular, we've seen that children left behind and the elderly. I'm at the moment in Nepal, in Kathmandu, and Nepal is one of the largest sending countries of migrants, and there are lots of these villages and lots of areas where you have elderly taking care of many children, and they are not in any way prioritized. So I really think that this is something, again, that migrant workers on the whole, also in their countries of origin, are not often given the accolades that they need for the remittances. In Nepal, for example, 1/4 of the economy is remittances sent by Nepali workers from abroad. And they really don't get, I would say, not just the recognition, but even their families do not get the services and the care. So I think it has to also come from maybe the workers themselves, but also from the communities where the workers belong to. And a lot of the time, the workers belong to communities that are remote and communities that are marginalized in many ways. So I think we have to start at the community level when it comes to those, because often going to the national level is very hard, because the national level, I often feel that it's like hitting against a brick wall. And they will say, oh, we will do this and it will take us 20 years by the time we can get the legislation or get the funding, etc. So the local communities that actually see the benefits of the migrant workers, that's where one has to start.
Great, thank you. We also have a question from Betty Volder-Levin noting that you mentioned anthropologists, and asking if you see a bigger role for anthropologists in trying to fill some of the gaps you talked about in your talk.
Absolutely, because I think that, though I have always been a numbers person, and I love my numbers, and all epidemiologists love numbers, and we work with numbers, but the numbers tell only half the story. The rest of the story we have to elicit from qualitative data. And I think that's something that we really don't have a lot of. And therefore we have to work with the social sciences, and we have to understand the story behind the numbers. And I think if we're going to work with people and we're going to work with changing pattern, behavior, all of that, I see there's a role. But what has happened earlier on is that the disciplines have done their own bit, but now we need to connect the dots. So that's where we need to work closely together and have multidisciplinary teams where we all work with one particular research question or research area, but have a team of researchers that actually complement each other.
Great. We also have a question from Allison McCullum, who's asking if there's anything, are there lessons for migrant health that can be learned from the ongoing work around indigenous, nomadic, and traveling peoples who have similar histories of exclusion and stigmatization?
Absolutely. And actually, the global society that I chair is not just migrants, but it also is really a global society that looks at including indigenous people and people who've basically been excluded or discriminated against. So there are lessons learned, you know, and there are similarities, but there are also differences. I think with the indigenous people, the history is much longer, that they have been in that particular country much longer than, for example, the migrants. The reason, and even in countries like the US, it's not that old in terms of, you know, recent migration. It's about 200 years old or 100 years old also. But indigenous people and nomadic people, it's much older than that. So I think that so there are things that will function. The other things that I would say is that the disease patterns and the disease burdens might be a bit different. So when it comes to the processes, yes, there are a lot of similarities, but of course, because the indigenous people have been living in those areas, those risk factors and disease burdens will be different compared to migrants who might be coming from different geographies. So that would vary very much.
Okay, thank you. And we also have a comment from one of our participants, just thanking you for your presentation and emphasizing, as a migrant, he or she is a migrant and feels very strongly about many of the things you said. I would just ask one question to end, Bernadette, before we turn it back over to Jim for a closing. And before I say this, I just want to acknowledge, as Ayman did, but your support, your encouragement, your contagious can-do spirit has been so important to the center as we've developed. And I think with all your experience and colleagues, you've been so welcoming, and not like you're a new center, what you can contribute, but just embracing the idea that there would be such a center from New York City. And we are so grateful for that. And I think one of the, it may be one of the lessons from the US, or comes from lessons from the US and New York City, would be, you mentioned the political as being a factor in what happens and how migrants can or cannot access health services. Is that even more than a factor? Would you see that as a prerequisite? I mean, can you increase access to health services in hostile political environments? Can increased access or increased recognition of the right to health drive political change, or does the political openness always have to precede what happens from a health point of view?
Yeah, it's a bit like the chicken and egg here. And I think that's probably what you were alluding to as well, Kathleen. I would say that just like we have the social determinants of health, the Lancet actually did have a commission that worked on the political determinants of health. And you know, earlier on, we've always worked with a little bit with blinders and tunnel vision, saying we're working with health and health is not political. Health is just political as much as anything else. And I think we just have to recognize that. However, just like with everything else that is political, we can't just say, okay, because the politics of it is not working, that we're going to not work with it. So I think it depends very much on, and it's interesting because sometimes it doesn't matter if you have a particular type of government or you have a particular type of political environment, because ultimately what matters is the people. So I often say, okay, you might have a political situation that is not in favor of this, but then look for the people, because you have to go to the individual level at the end of it. I mean, they're also going to, and then use the argument, which is the best argument. And maybe the rights argument is often not the best argument. And I have seen often that the rights argument really, though it's the most solid argument, fails because, you know, people feel that it's too overwhelming. And that's why the humanitarian argument often triumphs over the rights argument. So I think that what we have to do is, even in a hostile political, situation, it is possible, but it is very much dependent on the people, the communication, and what kind of communication one has, because if it's a hostile communication, it's not going to work. So I think that requires a lot of trust, and the relationship has to be built up at the community level. So, which is why I come back to and say, okay, before we go the governor or the mayor or whoever, it has to be at that community level, the community leaders who one can really talk to and convince and work with them, rather than starting at the top where you might be faced with a straight no. And I think that's the thing I would say that I've seen work best so far when it comes to migrant health.
Thank you, Bernadette. And it reinforces this one of the center's priorities, which is to work with community-based migrant refugee serving organizations in New York City to really learn from them and to lift up their voice. So Jim, I would turn it back to you, just perhaps for a question and a closing.
Thanks, Kathleen. I think it'll be a comment and then a question for closing, but I want to come back to the framing of these issues, which are so important, and noting when we were beginning our own work to start the center, and within New York State Department of Health, Immigrant Health was actually buried within the tuberculosis control program, which you wonder why and how, but you can imagine back to your comments on Ellis Island and the derivative of that. And I'll get to my framing in a question, but just a little quick personal update. I do remember when we first met. Very specifically, I just wanted to let you know that the 10-year-old that was accompanying me at that point was installed this week as the Deputy Assistant Secretary of Health at HHS, and the 8-year-old who was accompanying me was deployed from that same department. She's a public health lawyer, was deployed this week to our southern border, where she is now on a US military base doing, what we would never have imagined would have happened in America, but here we are. So, but I want to go back to the issue, which is also a little historical, because the other point is when we first met, was not in India or in Oslo. It was actually in Jerusalem. And there you had a ringside seat to what were the Oslo Accords. That's, of course, back in the news. We can't help it if we read the newspaper. And so my question to you is about when Native populations are viewed as outsiders, and relating to a question I might have asked you in Oslo, but should have, in terms of the framing of the issue and how you frame the center. Because as you frame the Center for Migration and Minority Health, that was very deliberate, as I recall. So I'm not, and I think we discussed that framing wouldn't quite work in the US or maybe, or whatever. Anyway, I'm just giving you open space here to kind of tell us where you see on the framing issue these elements relate to each other.
So we have a lot of issues regarding which groups, and I think one is trying to really get as many groups as possible. And the reason we have that is because of the language. And sometimes there was this whole question of how many generations do you have to have lived in a country before you're not a migrant? And the thing is, that's when you are not a migrant, but an ethnic minority. So there are all these transitions and identities. What we've not talked about today, and I've not done that because there's no time to really talk about, is identity. And it's also, we've not talked about ethnicity, identity, race, any of these issues that actually is not about how others look upon you, but also how you look upon yourself. And I think that is very important. So in the framing, we have to look at both identification of individuals and groups by themselves, and also how they're seen upon by others from the outside. The host population one day can very well end up being a migrant population elsewhere. So this happens all the time, that you shift your identity. So you could be part of a majority, and then you become a minority or a part of a ethnic minority group. So I think that it would be very hard to say that we have one standard, but what we need is a framework which is as inclusive as possible of people who are at a disadvantage. And I'm always saying that, because the SDGs say we leave no one behind, we have to look, and I have to say personally, I really, despite all the years working, because of all the years working with the UN and talking about vulnerable groups, it's almost has a negative connotation, because often I think that migrants have so much of resilience and they have so much of courage, and my goodness, the things they've done. So I think we've got to look and say, but what is a problem is the system that puts them at a disadvantage, not necessarily the individual. So I think we've got to begin to look at it from a system lens, not just an individual lens. The identity has to be from an individual perspective of how I define myself. And that definition has changed. And I always say, okay, who are you and who am I? And yes, if you'd asked me the question 30 years ago, I would have said, I'm Indian. If you ask me the question today, I'm not going to say I'm Indian Norwegian, but I'm saying I'm a global Indian Norwegian. Because so I think that definition is also dynamic depending on where you are and what you're doing. And that's the actual beauty of it. So we need to keep that there. We need to keep that a bit open. At the same time, we've got to look at the system level in terms of disadvantage, because the system is the one that actually defines people in or out of the system. And that's where you have privilege and non-privilege. I hope that helped a bit of the framing, Jim.
Thanks. Thank you, Bernadette. I won't wrap up the conversation. I will just note the continuation of it, that we'll keep this going. I'm also recognize that you are not only a global Indian Norwegian, but you are a global Indian Norwegian in Kathmandu, and it's nearly midnight there, I appreciate. So on behalf of Kathleen, Elizabeth, Diana, Rishi, and of course, Ayman, both our Dean and Center colleague, I want to thank you again for not just your talk today, but for all of those small talks along the way, outside of the media and outside of the limelight, moving this thing along, and now helping to move us along in terms of our center. We welcome you to it. I'll reinforce Ayman's point there. We're looking forward to making this a very regular activity, where our continuing discussion around these important issues. So again, thank you. And if we had an applause track, you'd be hearing it right now.
Thank you very much.
Thank you.
Thank you.
Thank you, Bernadette.
Thank you.
Thank you so much. See you again soon.
Thank you.
See you at